Hi, everyone. Thank you so much for joining us this evening. I'm Shibani Matani, a correspondent governor at the Foreign Correspondents Club. And it is my pleasure to introduce the Future of COVID-19 Pandemic panel, where we'll discuss what happens next and the trajectory of the pandemic with three very, very knowledgeable experts here. Before I get started, I just wanted to preview one of the events that we're having at the FCC this week, which is the final US presidential debate breakfast tomorrow morning. So please do join us for that. Onto the panel. It's my pleasure to introduce our three speakers tonight. Dr. Sarah Borwein. Dr. Sarah Borwein is a Canadian general practitioner who trained in infectious disease epidemiology at the London School of Hygiene and Economics. Before requalifying in Hong Kong in 2005, she worked in Beijing, where she ran the infection control program for the only expatriate hospital there during the SARS outbreak in 2003. We also have Professor Ivan Hung, who's a clinical professor and assistant dean at the University of Hong Kong's Department of Medicine. Educated at the University of Bristol, he specializes in infectious diseases, gastroenterology, and hepatology, with special research interests in vaccines and innovative treatment of severe influenza. We also have Professor John Nichols, a clinical professor in pathology at the University of Hong Kong. He graduated from the University of Adelaide and moved to Hong Kong in 1988, launching research into the relationship between viruses and the respiratory tract. He was part of the research team at the University of Hong Kong, which isolated and characterized the SARS coronavirus in 2003. And moderating will be Christine Zavando, who is a fellow correspondent board governor, and also the deputy head of Asia Digital at Bloomberg News. So take it over to Christine. Thank you so much again.
Good evening. Thank you again for joining us. Yes, so getting started today, as of today, COVID cases are at 41.3 million. It's killed 1.13 million people, confirmed deaths. Where are we now in the pandemic, and what are the major new insights that scientists have gleaned about this pathogen? Maybe you'd like to take it first, Dr. Hung?
Yes, thank you. It's a very good question. In fact, I think with the virus of course, we know that this is a novel coronavirus, and it's basically the virus itself is very similar. In fact, 80% similar to the SARS 2003 coronavirus, and about 96% similar to the Bats coronavirus. That is likely to be the origin of this COVID-19. In terms of the pathology, we know that the virus itself is very transmissible. It's much more transmissible compared to the SARS coronavirus 2003 because of the difference in the spike protein that allows the virus to attach to the human cells. And also that we know that recently there's a mutation, the D614G mutation of the spike protein, allowing the virus to be even much more transmissible than it was first happened in January, and probably 10 times more transmissible. Nevertheless, the good news is the virus itself is less lethal compared to the SARS 2003 coronavirus. And the mortality rate currently stands at about 2.8%. But we expect that to further come down with the better diagnostic, with the more people being diagnosed. Then the denominator will be higher, and the mortality rate hopefully will be coming down. And also that we know that from many of the recent research, we know that this virus is very good at suppressing the host immune response by suppressing the interferon response, and hence allowing the virus to replicate very rapidly. And some recent research published in the Science have stated that, of course, the severe cases is associated with some autoantibodies against the interferon. And I think that the virus is able to replicate because of the immune suppression that it poses on the host.
So you've covered what is known about the virus now, but what is unknown about the virus that scientists are trying to figure out? Maybe John, would you like to take the question?
Okay, so I think as Ivan's mentioned, we know quite a lot about the basic biology and how much it differs from the other coronaviruses. But what we really don't know is that how much is it going to mutate in the future? As he's mentioned, there's this small mutation, because these things called coronaviruses is that their proofreading mechanism is not as good as some of the other viruses. So like influenza, you're always going to be getting a few little mutations which come in. So it's still one of these stories which we still don't know much about what's going to happen next year, or 6 months. Could it change dramatically? Will we get another strain? But as Ivan's mentioned, I think it's been quite amazing that within the past 9 months, the amount of information we know about what it does within the body, and how we can actually then start tailoring treatments to try and modulate its effect.
Could some of you talk a bit more about, so we know what it does inside the body, but a lot of it also deals with what happens to the virus outside the body. Could you talk about what happens, what do we know so far about how it behaves, say, on surfaces or in the air?
Yeah, I'll take that one. So basically, this is what, there's been lots of studies coming out about how long it survives on surfaces for, and it's much more stable than some of the other coronaviruses. And there's been studies which say that basically it can, especially in the cold, it survives much longer, which is why there's been a couple of reports that just came out just a few days ago about they're finding the viable virus on the frozen seafood. And so I think then the evidence is that, unfortunately, is that it likes colder weather. It likes sort of to be indoors rather than outdoors, which has got bad news for coming up in what maybe for the winter. I've actually also just been doing some work with the aviation industry. We've been looking at how long the virus can actually survive on aircraft surfaces for. And the good news is that it's only viable for about 1 to 2 days, and it's not as viable as in other environments. So I think there's been a lot of work done. But one of the cautions which we must have is that how much can you translate this into how much it's still infectious to people? Because we still don't really know really how much virus there can be on a surface before it can actually infect people. But that's surfaces. But most of the work has been done on how long it can actually survive in the environment, in aerosols and the air. And that's very much an ongoing study about the transmissibility.
Sarah, did you want to add anything?
Just that I think that the other really important thing we don't fully understand yet is the immunity to the virus, and how good immune response we mount and how long it lasts for and how effective it is, because we really haven't got long enough to see if people get reinfected and what happened. We've had a few, but not enough to really know, and because it hasn't been long enough. So Ivan can speak much more about the virology of that, but there's still a lot of unknowns.
Mm-hmm. And you mentioned, John, about how the virus thrives in cold weather. Yeah. I guess the big question, I think you touched upon it, but could we talk about it further? Will there be a winter wave of infections?
Yeah, I think we're already seeing that in the Northern Hemisphere. Especially North America, UK, as it goes into the colder. And there's a number of reasons for that. The virus is more stable. And number two, people are indoors, so they're going to be more closer contact. And then also some work which we've been doing is also looking at the interaction of the COVID with the influenza, is that the influenza is able to change some of the receptor proteins for the COVID. So there's quite a bit of interaction on that. So I think we're already seeing the detrimental effects of this winter peak both in these North American countries. So that's why I think the countries are now being a little bit more proactive in the terms of the lockdown. As Ivan, I think, mentioned before, Hong Kong has been relatively well spared, and hopefully, because we've been wearing masks and we've got good social distancing, we won't be as badly affected as some of the other European countries.
Mm-hmm. Would any of you like to?
Yeah.
Anything?
Just want to emphasize what John has been saying. In fact, there are recently like 2 or 3 publications on looking at the temperature change and how it's going to affect the infectiousness of the virus. And I think there are 2 papers from China and 1 from Japan. All 3 papers are stating that if the weather is colder, the temperature got down to around 10 to 15 degrees Celsius, then the virus is much more active and the transmissibility is much better. And it's these that we worry about, especially among the elderly population and subjects who are in the elderly homes, who are in the indoors, who will be at risk of this outbreaks, especially in winter. And similarly, we did see patients who have co-infection, not with influenza, but with rhinovirus infection. And we had like 2 or 3 patients who had come down with rhino together with COVID-19. And definitely these patients have much longer time to clear the virus. Most people will clear the virus probably around 7 to 10 days. But these people with co-infection, that actually take them like 3 weeks before they are able to clear the virus. And they have more chances of having complications of pneumonia. And of course, a few actually have more severe anosmia, actually losing the sense of smell and taste, which is very special signs or symptoms for COVID-19.
Yeah, can I just touch on that, because the some of the work which we've been doing using hamsters, which are actually a good model, shows that this COVID only replicates right in the back of the nasal cavity in what's called the olfactory mucosa, which is why both patients and you get this loss of smell. One of the things which keeps me awake at night is that if you couple this with influenza, because influenza can do the nasopharynx and the nasal cavity, and that's associated, as all of us know when we get influenza, with far more coughing and sneezing. With COVID, you don't get as much of those symptoms. So in terms of the coughing and sneezing, my concern is if you get a double infection, then you're going to be getting far greater transmission of the coronavirus because of this forced coughing, sneezing, rather than just the breathing. So that's one of my big concerns, which is why sort of yesterday I had my influenza vaccination, just to be a good boy, because I think that's going to be one of the crucial things is to try and mitigate that.
Yes.
Once you get these 2 viruses together, I think
it's very important that people get their flu shots, and that potential concern is a very real one. But actually, what happened last year was we had almost no influenza. It stopped very quickly after we started wearing masks and washing our hands to prevent COVID. And so my hope is that although it is a real fear, and I really do want to encourage people to get their flu vaccine, the hope is that the same thing will happen this year and that we won't have a large influenza outbreak. That would be the best scenario.
Well, Sarah, you've just mentioned one of the burning topics right now, which is the vaccine and when it will arrive. So I guess I should ask you all, when do you think this vaccine will arrive, and how much of a game changer or a magic bullet, some say, will it be? Maybe Sarah, would you like to take that first?
As to when it will arrive, I really don't know, because as we've talked about amongst ourselves, several of the trials are currently on hold. These things always take a little longer than you think, because they do get stopped very quickly if there's a potential side effect in any participant. So they always take longer than you think. It's just we're watching so closely now that we notice this. So I suspect it's going to be mid next year personally, but I don't know. And how much of a game changer it is, it depends really how effective it is. The less effective it is, the more of the population we need vaccinated to make a difference. And so that's the sort of unknown. My own suspicion is that it will be an important piece of the fight, but not a magic bullet by itself. I'd love for it to be, but I daren't hope for that.
Maybe Ivan, you'd like to add anything?
Yes, I think it's not a magic bullet, but it's a major weapon that we have. I'm probably a little bit more optimistic, but we will be talking about probably Q1, the first quarter of next year. Then finger crossed that we will have at least 1 or 2 vaccine available. I mean, there are like 4 or 5 vaccines currently in the phase 3 trial, even though some of them are currently on hold because of some so-called adverse events that happens in the trial subjects. But hopefully that they will be resumed quickly, and then they will have the results ready once they are, published and they get the approval from the FDA. Then hopefully that will be in the market very soon. And I think a few major pharmaceuticals have already have the vaccine being produced and ready. Once it's been approved, then they will release it into the market. In terms of the vaccinated group, then of course will be those, elderly subjects will have the priority to be vaccinated, and also the healthcare workers will get it vaccinated first. The question remains, of course, is how long these antibodies are going to last. Judging from the people who have recovered from the natural infection, the current antibody lasts around 6 months, I think, for most of the recovered subjects. So I think for vaccine will be very much the same, very much like influenza. So it will probably cover for about 6 months, 6 to 9 months. Then you might need to have an annual vaccination similar to influenza for COVID-19.
Okay. Well, I'm going to be the negative person. Is that China says they'll be able to get 1 billion doses. However, just yesterday, South Korea says 60% of the population will not be vaccinated, do not want a vaccination. US, about 50% of the population do not want a vaccination. And in Australia, it's about a similar number. And that is going to be the big problem, is that the middle-aged population, the younger population, we can't even get them to have an influenza vaccine, and they're the sort of people who's going to be a very hard sell. Those of us in Hong Kong, we know how much it was a hard sell for to even get this mandatory testing. There's a swabs. So I think that having a vaccine is going to be far harder, and all you need will be just a few negative reactions, and I think people will go off it. And then the other problem is that, as Ivan sort of touched on, is that if we use the influenza as an example, the big problem with all these vaccines, most of these vaccines, is that they will stop the middle-aged people from getting the pneumonia, but they do not stop transmission. And so you still get transmission. So you're still going to get the transmission because you don't get unless you use the nasal vaccine, because you won't get the immunity in the upper nasal cavity. Then so that's the part of the problem. And then there is also a very nice thing called immune senescence, which is a fancy word, which means that the older you get, the less basically antibody response you get to a vaccine. And so basically people like me who are over a certain age, is that basically you can give us a vaccination and we won't get as good an immune response as a young person like Sarah. So that's why, or you. And so that's why you sort of, even Ivan said, we target the elderly. The problem is that group, which is the most susceptible to getting the severe disease, is going to be one of the most challenging to get the proper antibody response in. So, so that's and then the other problem is that most of these vaccines is on the, unlike flu vaccine, which you can keep about 4 degrees, my understanding is most of these require a very strict cold chain storage, which means that they have to be kept minus 10, minus 20 degrees Celsius, which is fine for sort of Hong Kong, where everything's within 20 minutes of a major hospital. But my concern is that even places like rural China, Africa, parts of Central Asia, you won't be able to get that cold chain storage. So that's going to be a big logistical problem of, once you do get a vaccine, of actually making sure you can actually get it to the population on that.
That problem is there's 10 vaccines currently in phase 3 trials, as far as I know. Two of them are mRNA vaccines, which is a new technology, very clever technology, and has a big advantage that you can make these vaccines quickly and they can be flexible. You can change them if the virus mutates. And basically they insert the genetic material into the cell to induce it to produce the protein that your immune system responds to. They get stored in a lipid, a fatty kind of capsule that's very temperature sensitive. And those those vaccines that are the mRNA vaccines, I think 2 are in phase 3 trials. No vaccine of that technology has ever made it to market before, so it would be a first. And they are extremely difficult in terms of their cold chain requirements.
Absolutely.
So the distribution, as John says, would be incredibly difficult. There are other vaccines. The Chinese vaccines that are in phase 3 are all inactivated vaccine, which is just an old virus, which is an old technology, kind of tried and true. That, you know, is a bit easier, but we don't yet know how good it is. And then the AstraZeneca and the Johnson & Johnson are virus vector. And again, they're clever technology, but never been brought to market before. So we're hoping that they work, kind of, but haven't tried it before, really.
Yeah, so
just want to add a few things, what Sarah has been saying. I think for the RNA vaccine, the problem is that it is very immunogenic. But the problem is that it's very unstable to temperature. So the problem, of course, will be delivery from the manufacturing country to the country that you want to get it vaccinated. And I've been talking to my pilot friends from Cathay, and it's been they are already saying that it will be extremely difficult to arrange these delivery from one place to the others for the vaccine, and they will need many flights to make these delivery. And the problem
which is good for Cathay.
It is.
Very topical.
For the pilots, of course, yes. And the adenovirus, of course, the problem is that they are human adenovirus, especially for the vaccine from China and the one from Russia, which, of course, many of us do had an adenovirus before, and hence they will have antibody against the vector. For the AstraZeneca one, of course, is a chimpanzee adenovirus, so it is definitely much more stable compared to the human adenovirus.
We're less likely to have pre-existing immunity to that virus, so it'll probably work better.
Okay. So yes, let's just think about vaccine distribution once we actually have it. Actually, you touched on a question of, again, cold temperatures, and we have 2 questions from the audience right now. And one is, why has, but you mentioned this earlier, John, why has frozen fish packaging emerged as a theme in China's pandemic battle? And is it more than just coincidence? Is there a link between a specific, seafood and coronavirus?
I don't think it's what's happened is that in Europe and in the US is that there's actually one of the hotspots has actually been the meat packing industry. The reason being is that that's where you get people who are working close together. I don't say I'm profiling, but many of these may not have had proper training in infection control. All the meat and things has to be kept at a very, very low temperature. You got blood and everything is sort of going everywhere. And so then the moment you have the meat, it has to be frozen so it can be shipped. And many of the major outbreaks have actually occurred in those meat packing industries. And so I think it's not surprising that frozen seafood, frozen meat that's where you're going to be getting basically clusters. And we also have to be very, very careful is that when New Zealand, about a number of months ago, when there was thought to be the seafood, is that you have to be a difference about whether or not you just find what's called the RNA or the infectious virus. The studies which were done before just found basically the genetic material. But my understanding is that in China, they actually found the infectious virus, but it's in very, very low concentrations, which comes back to that question I put forward before, is that at this stage, we still are not very clear about how much you can have on a surface where it can be infectious to humans. in our hamsters, you needed 100 copies to be able to infect a hamster, but we're not hamsters. So I think that's one of the unanswered questions about the role of surface in terms of the spread of the virus.
I think it's important just for people to also understand that the major way the virus is spread is through respiratory droplets. And so surfaces, of course, are important, and we must wash our hands and continue to sanitize. But at the beginning of the epidemic, there was a lot of what is being called hygiene theater, where there was an obsession about cleaning surfaces and perhaps not enough attention to the respiratory droplet spread part of it. So it's still very important to remember that your major risk is from the respiratory droplets.
To that point, what is our existing best defense against the coronavirus while we await a vaccine and an effective treatment? Maybe Sarah, you'd like to?
I mean, I think that the best defense is still public health measures. And I think one thing we learned from SARS, and we've seen it again this time, is that effective and comprehensive but simple public health measures can control an epidemic if they're applied early and consistently. And so for us, it means we wear masks, we wash our hands, we avoid mass gatherings, we keep our social distance, and we cooperate with the testing, tracing, isolation, and quarantine procedures that have been very effective in managing the epidemic. That all sounds great, but it's actually harder to get people to do than it might sound, but that is really our best defense. I think the other things are early treatment, which Ivan can talk more about, but early treatment is an important defense against getting very sick if you do get coronavirus. Keeping yourself healthy, don't gain the COVID-19, which many people have, and get out in the sun and look after yourself. And I think the other really important thing is to try and look after your mental health, which of course is important, not just for we want people to have good mental health, but the other thing that happens when people don't look after their mental health is that this COVID precaution fatigue sets in, and then people get less careful. So it's really important that we pay attention to that and find ways to maintain our vigilance through this kind of long haul that we're in.
Is there anything you'd like to add, Ivan?
Yes. Again, Sarah just pointed out, I think the basic infection control, including masking and also hand hygiene and social distancing, are probably the most important measures. And testing, easy accessible testing, will be very important for early diagnosis. And of course, if you have early diagnosis, then that will allow you to be hospitalized earlier for those symptomatic cases, especially those with pneumonia. And that will allow us to intervene by treating the patient within the first week of symptom onset. If you're able to treat the patient in the first week, then with the current repurposing drugs like interferon, with ribavirin and Kaletra, this kind of combination, or remdesivir, even though that they may not be the tailor-made or specific antiviral, but with a combination of antiviral together, and you give them earlier enough, then they will be able to suppress the viral load. And once you're able to suppress the viral load, you are able to stop the second week, so-called the hyperinflammation, the cytokine storm, and you will be able to reduce the complication and also mortality as a result. And that has been proven. Even though our triple therapy is for mild and moderate cases, we are seeing basically better, much quicker symptom relief, and also the viral suppression. And again, a similar study has already been published for MERS recently in New England Journal of Medicine. Again, the combination of interferon and Kaletra is able to reduce the mortality for MERS, severe MERS. Many of the study that was carried overseas, abroad, have not been able to show a difference in terms of mortality. And I think the reason is because the drugs actually been given too late, right in the second or the third week from symptom onset. And by that time, you won't be able to do anything because the lung is so inflamed then nothing will be able to get in and is able to suppress the virus and stop the inflammation. So
I think
again,
that's a really important point, because it informs why it's important to cooperate with early testing and being admitted early, because we know this disease is very mild often at the beginning, but may get severe later on. So people shouldn't be lulled into the idea that because they have only mild symptoms, they don't need to get tested and treated. Because as Ivan says, the treatment needs to be given early before you get really sick, not wait for you to get really sick.
Actually, we have a relevant question on testing from our audience. This is from Bernard Murphy. He asks what your views are regarding recent media coverage of the government considering possible compulsory government testing. And do you think that this type of mass testing is a good and useful strategy, or is it just, quote, wasting bullets? And
well,
yeah.
I think for the mass community, testing is only, I think, effective if you can cover like 70% of the population, and you can finish it within like 3 or 4 days. Then you'll be able to capture all the so-called, asymptomatic cases, or the patient who have no symptoms, and you're able to take out these asymptomatic cases and silent cases, and you'll be able to hospitalize them or quarantine them. Then it will be useful. But on the other hand, if you carry these over like 2 weeks and you are not able to reach the target number, then it will be the effectiveness of these kind of mass community screening will not be very useful, because that the virus will move on, it will keep on transmitting, and you will be missed those cases who have previously was negative, but then they become positive in the after you have done your testing. So it only be useful if you can cover like 70% of the population, and you can do it within a few days.
Yeah,
just like what China is doing.
Yeah, I'll look at it from the laboratory point of view. When it was tried in Hong Kong over the 2-week period, the feedback was, we had people saying that they were, working 24 hours a day. They couldn't take toilet breaks. So, so they could get all the tests done. From a laboratory safety point of view and a science point of view, that is not good, because that's not, I would not consider that a safe working environment. And and if we had that, and over a 2-week period, we had people working round the clock to do 1.8, 1.9 million samples, then unless you're going to be doing the pooled testing or large, then basically we would not have infrastructure to go through that. As Ivan said, if you're going to be doing it, you've got to get a feedback within a couple of days, and to have a population that when they're doing it is that where they are, they're going to be hopefully staying at home. So if they are positive, you're going to be picking that up. So it's good. I think only a few places have been able to do that, but I think that it is not, from a consumable point of view, I don't think it's sustainable, because as I've been pointed out, we can do it at the first week of November, and then when do we next do it? First week of December, or do we just not do it anymore? It's just I think it's a big logistical challenge.
If you make it mandatory, how do you enforce that? And it's a big problem. China has done it successfully on a couple of occasions, kind of more reactively to small outbreaks. But the amount of resource that's taken has been enormous. Is it a good use of our resources? I'm not sure.
Nevertheless, I think it's important to increase the capacity of testing in Hong Kong by having more machines, and probably employing more people who will be able to do the testing. Then that will be able to enhance the working to keep the working hours to minimum, and to a more better, and in terms of the safety measures for these technicians, so that they won't be working really 24 hours nonstop, which is simply not healthy and not safe at all, as John have said.
While we're on personal best practices, maybe you could indulge me in sort of just a couple of minutes of round robin where I ask you questions from fellow board governor Christy Lou Stout, who I think you all know. Maybe we could go one by one, and maybe you could give just very short answers. And if they're yes or no answers, just say yes or no, or feel free to pass if you don't feel like answering. But yes, maybe we could just take the time. Starting with maybe John, Ivan, and then Sarah. So when and where do you wear a mask? When and where do you wear a mask?
Okay, so I within the MTR, I wear a mask. I wear a mask when we're in the hospital. When I'm on the MTR, I will wear a mask. However, okay, I'll be shot down for it. If I'm walking to or from work, I don't wear a mask. I don't. I don't see there's any need. It's a bit of fresh air, and masks can get a bit clogged up at time. But that's about in anywhere where there's more than 2 or 3 people together, I will wear a mask. But at home, I don't wear a mask. And as I say, if I'm going out running or walking, I don't wear a mask.
Ivan?
Yeah, similar to John. I think in public transport, in hospital, I'll be wearing a mask. While indoor with, in a meeting, I'll be wearing a mask. But if I'm outdoor exercising, playing football, running, then I won't be wearing a mask. And again, if I'm alone at home, I won't be wearing a mask. In my office, on my own, I won't be wearing the mask.
Sarah?
Same. I don't wear a mask when outside exercising, but whenever around other people, certainly at work all the time, then I wear a mask. When they had the mask mandate that you wear it all the time, even while exercising, we did get these little plastic cups that you can put inside the mask that make them more comfortable to exercise in. So in case they introduce that again, I have a stock.
Next question is, what kind of mask do you wear? John?
It's the ordinary sort of surgical 3-ply one. I will also say that I will use it for more than one day because I do have a bit of concern about the environment. I sort of know that enough of how much virus is going around it in the community that I will wear it for a couple of days. Rather than throw it out every day. That's because I say I'm worried about what's washing up on the beaches and all and how many trees have been cut down on that. The boys have, my kids have got the cloth masks. I don't have any problems with that. If they can wash them, then it looks a bit more trendier than ordinary blue masks. I don't wear the one thing which happened was that in SARS is that those N95s, unless you've had a fit test done, which you have to do to work in the hospital, if you haven't had the fit test done, they're useless, and they're a pain to wear. They're suffocating, so I've got one in the office, but I haven't worn an N95 for a long period of time because I'm not in the high risk.
Interesting. And Ivan?
Again, it's a level 2 surgical mask, or level 3 sometimes, for my daily routines. But it's only, and I usually have one mask a day because I tend to be in the hospital seeing patients. But I only wear my N95 when I'm in the isolation ward, which I would basically do it every day. When I go in and see my patients, then I'll be wearing my N95 mask. And even for N95 mask, we tend to use it, we keep it for the first, while rounding our patient, we keep our N95 mask on because we can just change our face shields. without taking off the N95 mask. Because when you take off the N95 mask, in fact, there are risks. It's when you take off the mask, then you tend to contaminate yourself. So we usually keep the N95 mask on and just change the face shield when we see move on to one cubicle to the others.
And Sarah?
Wear surgical mask, same. N95 is too uncomfortable unless in an isolation area or doing a procedure that is high risk.
And I guess a last round robin question. This is a yes or no. Are you willing to fly internationally? Should there be travel bubbles? John?
Okay. I want to travel. Basically, I like traveling. And I think that we should, I see no reason why we cannot have a travel bubble with, for instance, Taiwan. They've had 0 cases. Macau. Why we've we still have this 2 weeks quarantine. Singapore, we like there, but the detriment is going to be the pain of sort of having a test here, test when you go there, test when you come back. But I think we need a travel bubble for the economy, and this is where it comes back to the vaccine. Is that why I'm sort of a little bit pessimistic? Is that yes, you can vaccinate if necessary the whole of Hong Kong, but if you're going to get places like the US which don't have a vaccine, then you won't be able to open up to the US. You're going to have a similar situation. So my personal view is that I think we should be opening up more with the realization that we have to sort of be a little bit more responsible about sort of trying to give people a bit of sense of more responsibility. And the aviation industry needs something like this, and the whole tourism industry needs to have a bit more of a travel bubble. That's not a yes no question.
So maybe is your answer. Ivan?
And again, I like traveling, so I very much for the travel bubble, but again, it's like places like Taiwan, Singapore, Korea, Japan. These are places. Then hopefully we'll be able to have a travel bubble with. Even though we probably need the testing to be done within 72 hours before you set off, and then when you come back, you still have to have your testing done without quarantine. But that will be it will be very important for the economy, for the airlines, and for the tourism. And again, with that, hopefully we'll be able to encourage people to get vaccinated if it is proven to be safe and immunogenic. Then more places could be opened up as a result.
Sarah?
Yeah, I mean, what I see is the world moving in, that we have 2 big ships sailing. We have sort of Asia Pacific sailing into containment and kind of trying to suppress this down to pretty close to 0. And then we have the rest of the world where virus is surging massively. And so I think the idea of a travel bubble within the kind of containment zones is great. But probably it's going to be a long time before we can have free travel with the places that aren't in that kind of mode.
And I guess a last question that came in now, and you could just answer yes or no. Do you think beaches and schools should reopen? Is it safe to do so now that we have low case counts? John?
Schools are
yes
open.
or no?
But the schools are open. I mind seeing my kids are going to school, whether or not that well, at least they're going. So I think they're at school. So, but beaches, I for some reason I can't understand why beaches seem to be off limits. There must be some reason on that. But beaches, you got fresh air. You've got basically people. They won't be sort of too crowded together. It's a healthy environment. But it's just, the gazetted beaches which are closed, so people go to non-gazetted beaches. I'd like to see them, I'd much rather, I think they should be open, but obviously there's obviously political reasons why it's not being done.
Does anyone want to add?
And again, schools and beaches are, I think, you know, like in Hong Kong, are very safe. Schools, as long as you have, like, you know, you have students wearing masks at school, and you have a half-day school, because the high risk, of course, is during lunchtime, when, you know, the kids take off their masks and they gather together and chat while they eating. So half-day school is important, because if you have Zooming all the time, it actually, you know, reduce the learning, you know, abilities and everything for the students, and the student will not be able to interact properly with the peers, with the teachers. So it's important to try to, you know, get back to school as quickly as possible, like in Hong Kong, once you have very few cases. Unfortunately, probably for UK and US, they're currently not able to do that with the increasing number of cases as such. So they have to rely on Zooming.
Sarah, anything to add?
I think it's really important that we prioritize keeping the schools open. I think that should be really one, especially for younger children. Teenagers do better on average with Zoom than little kids who really need the socialization part of school. And so I think that should be it should be a priority, and we should do whatever we need to do as much as we can to keep them open. Again, I'm not quite sure what the issue is with the beaches, except that they do sometimes get really crowded. So, and you have a lot of people not wearing masks very close to each other. So perhaps that's the issue, but I think they're a good outlet for people.
Thank you. I hope everyone got a lot of tips from that round robin, but I guess the next question would be, you know, the other aspect of the pandemic, which is an infodemic, so a wave of misinformation or disinformation. What are the biggest misconceptions you've heard about coronavirus, and, you know, what are the lessons we can learn from past pandemics to battle them? Maybe Sarah, you'd like to take that?
Well, lessons from past pandemics, there's many. And I think one of the advantages we've had in Hong Kong is that we did learn a lot of lessons from SARS. It wasn't a pandemic, it was an epidemic, but it left very deep scars on Hong Kong, and we learned a lot of lessons. I think we learned very importantly that delay is deadly, that you have to act quickly. And actually, it doesn't even matter if you get it exactly right, all the measures you take, but you have to take aggressive measures early. Because if you wait until you've got a large epidemic, you're basically trying to push back a tsunami. And the only weapon left to you at that point is lockdown. And as we can see, I think you only get one go at lockdown because people won't cooperate with lockdown twice. So I think that was an important lesson. We kind of learned that you can't hide an epidemic, or at least not forever. That they don't respect borders very easily, not without great difficulty. And I think that we really have learned, and we're seeing it play out this time, that clear, consistent, honest public health messaging is really important. So we've had that here. I feel that we've had good public health messaging in Hong Kong and in other parts of Asia. But in other places, sometimes it's been inconsistent and confusing to people. And then they lose trust, and then they start to believe conspiracy theories. So that's really important. There's a saying that in public health, honesty is worth more than hope. So you need to tell people the truth in a way that they can understand it, not always be trying to just suppress panic. You end up doing more harm. I think we learned from SARS that about diseases amplifying in healthcare settings. We hadn't really seen that before. It was the first time, I think, we really used the term super spreader, which we know is an important feature of this epidemic. And we learned that you can contain an epidemic just by applying good public health measures very consistently. And so, and I think Hong Kong learned those lessons pretty well, and that's really one of the reasons why we have had good success in controlling this. So hopefully those lessons will be taken in the future. Go on.
I'm sure you have some insight to add, John, on that part about battling conspiracy theories and misinformation.
Yeah. Okay. Yeah. I think Christy will realise I'm guilty on some of those counts. Is that initially some things which we thought early in the outbreak didn't eventuate, But I think one of the big problems is that, unlike 2003, is that the role of both the Google and the lack of fact checking. So poor Joe Public, has a very difficult time knowing what's really true out there. And when you got Dr. Google and these people who have these cyberchondria, it's very they find it very difficult to know what's true and what's fake, and so so what is spreading is very difficult to challenge. It also comes down to when even things like the publications, is that there's been such a deluge of these things being submitted to all these preprint and which are basically some of the media pick up, and these have not been peer reviewed. But Joe Public doesn't know that whether or not that's valid versus something which has been peer reviewed and published. So actually working out what's truth and what's not truth is still very, very challenging. And I can understand why the public gets quite confused about what really to believe. Do I have a good answer to that? And the answer is no. As long as you have a free media, you're going to be getting alternative facts.
And then you add to it that it's become very politicized as well. So what you believe also in many areas depends on your politics.
No.
I think we need, I think we have free and responsible media that really kind of tries to battle that misinformation. But Dr. Hung, would you like to add anything about how we can battle infodemics?
Yes, I think for from the experience of SARS in 2003, I think we will definitely learn a lot from that epidemic, and because of that, we have each of the hospital now have isolation negative pressure room, at least like each of the cluster will have that. And I think these things are things we learned, and also early treatment, just like what we had from SARS, will be important, and combination drugs again will be very important. So these are things that we learned in 2003 from SARS that is able to help us to contain the COVID-19 in Hong Kong, these important infection control measures. And similarly, as I've said, as Sarah and John have said, about the basically politics influencing the these kind of and media influencing the information, especially for very early on we have been promoting the importance of wearing masks, but again certain countries are saying you don't really have to wear masks, you just have to have social distancing, and then of course that turned out to be pretty disastrous. And only after a few months, then they realized the importance of wearing masks. Another misinformation, of course, is young people who tends to have milder disease. Yes, we know that young people tends to be better tolerated and fewer complications, and of course most of them are so-called asymptomatic. But we do have severe cases in young people, and we do have young people coming down with severe pneumonia and even death in young people. So it's for young people, again, they should be taking these infection control measures very importantly. Otherwise, again, they will be not only harming themselves, but they will be spreading the virus to family members who are elderly. So it's important that they take these infection control measures seriously.
I think that brings up one of the problems that we've had, is that people tend to kind of go with these false dichotomies that, it's binary. You either die from coronavirus or you're fine. And so, most people think they're not going to die from coronavirus, and therefore they're not scared of it. But it isn't binary. As Ivan has said, young people are probably going to survive with good care, but they can get very sick. And so it isn't one or the other, just like there isn't a choice between locking down and fully opening up. There's an in-between, right? So I think that's important. And some of those misconceptions are feeding this kind of, I guess, myth that this isn't a real epidemic, or it's only no worse than the flu, and that's quite harmful.
We have a follow-up question from our membership. What do you think of the media coverage of the pandemic so far? Anyone have any views? Maybe Sarah?
You know, I think the mainstream media coverage has been quite good, most of it. I mean, of course, I watch what I watch, and there are some mainstream media that I don't watch, so I'm not sure. But as John's pointed out, the problem is that many people don't get their information from the mainstream media. They're getting it from social media primarily. And all kinds of stuff is on there. And we know that social media polarizes opinions. It shows you what you like to watch. So if you like to watch pandemic is a hoax articles, your social media feed will show you those articles, and then that's all you'll be reading pretty soon. So I think the mainstream media has done a pretty good job, but they're fighting against this infodemic.
I guess a last question before we the science shows that there will likely be other pandemics from animal-borne viruses. We've seen, you know, diseases from bats or rodents jump to humans, but where do you think this is likely to come from next, and how can another pandemic be avoided? Maybe John?
Yeah, okay. So basically, you know, because I've been working with influenza now for many, many years, is that, and I think we can use history as an example, is that wherever you're going to be getting a high concentration of an animal population with a high concentration of the human population is where you're going to be getting the mixing. So even though, you know, China may be able to stamp out the wildlife trade market, you know, I've been to Vietnam, I've been to Indonesia. You still have very much a rural, you know, rural economy, which is, you know, right next door and very close to a industrial economy. But wherever you get these two economies, which are basically in conjunction, that's where you're going to be getting the next outbreak. So it's you know, history will show it will be another come from another animal source, most likely a wildlife animal source. However, you know, just a few days ago, there's actually a pig coronavirus, which is now causing some concern up north. And there's a talk about, you know, can this one actually also infect humans? So it's going to be where you're getting mass animals are being bred for human consumption. That's where you're going to be getting it. So it's not going to be if, but when.
Ivan, would you like to add anything?
Yeah, I think it's very much you have to respect the nature and really you know, this happened in 2003 and again happened now for the COVID-19, and again is very likely to be related to the consumption of, you know, wild animals and wild animals being sold in you know, live markets, and again that allows the, for example, you know, the virus jump from bats to other mammals and to humans. So again, you really have to respect nature, and if you're able to stop completely these kind of market, then you would definitely reduce the risks of you know, another pandemic from an emerging viruses. But nevertheless, every time it happens, then it tends to tighten up. But after a few years, then people relax, and then everything just go back to zero, and then it's all started again. So really, if you really want to stop the next pandemic, you really have to respect nature and stop doing these kind of you know, live marketing and eating wild animals.
Lots of food for thought. So before we end, I guess this is a FCC trademark question, but we'd like to know what you've been reading. If you'd like to share any interesting books, doesn't have to be about the pandemic, but John, would you like to share what books?
Okay, here we go. Here's my hat, my North American hat. Okay, I say saying, see, I come from, I'm actually half American, and so I've been reading about the Middle East during the Second World War, because my grandfather was with the State Department, and he's got lots of papers which need transcribing. So I've been looking at this called Lords of the Desert by James Barr. Very good study about the battles which went on between the UK, US about the control of the oil in the Middle East around the Second World War and time after. That's my book.
Great. Ivan?
Well, I really hasn't had time to read any books recently. Basically, I've been reading all these scientific journals in the past few months. So the only books I was able to read is with my son, and basically it was on a book on with Bill Shankly on my favorite Liverpool Football Club. So that was the book I read lately, but that was already a few months ago.
Got it. And Sarah?
Well, I have to confess that at the beginning of the summer, I was sort of obsessed with the history of pandemics. And so I read a whole bunch of books about the history of pandemics, the Great Influenza by John Barry and a bunch of others. And then I got sort of COVID fatigue too, and started reading some fiction instead. So, and some non-COVID nonfiction. So I'm actually currently reading a book about the Kaduris and the Sassoons called The Last Kings of Shanghai, which is very interesting about the history of Shanghai and Hong Kong, but nothing to do with coronavirus.
Okay, great. Well, thank you so much for your time and sharing all your insight and tips for our club members. And yes, I think we'll end it there. And again, thank you very much. And see you soon.
Thank you.
Stay safe.
Thank
Thank
you.
you.